here. We are here in sunny, not sunny so much more anymore, Brisbane. Thank you guys so very much for coming all this way. I mean, we've been talking today about how crazy the last 2 years have been, but I really think like this is a huge light at the end of the tunnel for me and for all these people you're going to talk to. So tell us a bit about why you're here, because you're both here. So maybe introduce yourself real quick and just tell us a bit about why you're here in Australia.
I guess I'll start. So I'm Anne Peled. This is my husband, Steve Peled. We are all the way from San Francisco. I'm a breast and plastic surgeon, and we're here to talk about sensation-preserving mastectomy. And we are so grateful because we are here because of you. And so we really are, but so grateful to be able to have the opportunity to be here, to be talking with Australian surgeons about what we've been doing, about our outcomes, about the technique. I'm really so hopeful that we're going to be able to have this be an option for women thinking about having mastectomy surgery as a result of being here.
Yeah, amazing. And Ziv?
Yeah, so I'm a plastic and peripheral nerve surgeon. Yeah, couldn't be more grateful.
Yeah. Thank you. Well, first time to Australia, so that's exciting.
Yeah,
that's exciting. You need to come back and for longer next time. So that's
already got plans.
Good. So why did you guys? Where did this come from? Why did you guys decide, hey, we need resensation in breast reconstruction?
I mean, honestly, it all started with my own diagnosis. I think being diagnosed with breast cancer at 37 and trying to consider options, it was just so daunting to think about going through mastectomies and knowing that I wasn't going to have any sensation for the rest of my life. And I think for many people, you know, it's everything. It's from this whole part of your body that's numb. It's thinking about what that means for intimacy and body image. And I just no part of me could wrap my brain around it at that time. And so I ended up having a lumpectomy, but really, truly, in the weeks afterwards, even I were talking over dinner about we reconstruct nerves in other parts of the body, we preserve nerves in other parts of the body. Why couldn't we do it in breast? So we did a family surgery in January 2018, and then in February 2018, we did our first case together, which was preserving nerves when we could, and then reconstructing them in the setting of implant reconstruction. And at this point, I think we've done close to 5, all these surgeries, and I've been really excited to be looking at our data and really seeing that consistently the vast majority of our patients having this combination of nerve preservation and nerve grafting with implant reconstruction, or honestly now we're starting to do it for women choosing flat closure and other kinds of reconstruction. We're seeing that consistently, the vast majority of people are getting back to all of their sensations.
Even in flat closure.
Mm-hmm.
Amazing. Not even options in Australia until we started talking with you here in gosh, it's not even 12 months in.
Oh my
not
gosh,
even 12
look
months.
how fast you made everything happen.
I don't know. I think there's been a lot of really incredible things that have all come together that have made this possible. But yeah, I think the thing is when Australians, we have an excellent healthcare system here, but when there are new and amazing things out there, we need to make sure that they're available for Australian women as well. So coming to something like this is incredibly important because you're right at the coalface of meeting all of the people who are actually making decisions to learn these techniques. So what's your hope for this week?
So I started actually yesterday teaching an oncoplastic course and did talk a little bit about what we're doing as part of the talk I gave there on optimizing mastectomies. And what's really incredible is to see that people are really excited about it. And one of the things that we run into, I know you run into, is this concept of like, does sensation really matter? Is this worth fighting for, learning new techniques for, in some cases traveling to learn about it for? And what was great to see yesterday was I felt like the surgeons I talked to really understood that this was important and was worth learning more about. So my hope is that if we're starting, let's start talking to people. Let's talk about why sensation matters. Let's talk about why chronic pain matters, or that you could get burned because you don't feel anything in your chest. Like, let's start with at least raising awareness around it. Hopefully then get people to see that that is important. And then see when we talk about our technique, when we talk about our outcomes, that actually it's working and that it's feasible and it's really solving this problem. And so I think for me, that's really my hope, is that sort of full spectrum. Some people are going to come in at the awareness and just learning there. Some people already are aware, but don't have the technical part of it. So hopefully we get to explain some of that stuff. And then we get people who are really ready to start, hopefully. And we do have some surgeons here, which is really exciting. And so knowing that we can kind of, if Ziva's already been, mentoring mentoring them from across the world as they're getting started. And I think that's been really great. I mean, you feel like you're kind of mentorship and going through, like they're in a place, right, where they're doing it, they understand the techniques, they're getting it, right? And
Yeah, I think
conversations.
you've hit the nail on the head. I think it's a combination of understanding why it's so important and then understanding that it's technically possible. And then hearing from us and very soon many others, because we've trained a number of surgeon pairs, breast surgeons oncologically and plastic surgeons from a reconstructive standpoint, that the outcomes are really very encouraging to say the least. So it's a win-win for everyone.
Yeah, 100%. And I think for every woman that I've spoken to who's told me about their lack of sensation or their food, this provides what I was saying to you before, is that hope that there is something else out there and there's potential for the future to have something different offered. We were talking a bit earlier as well about some of the nerve damage issues that we sometimes find. So, I mean, if we're moving ahead, we also have to make sure that the basics are done correctly. So, what you thinking about that and about people who have that chronic pain based on nerve damage?
So the incidence of chronic post-mastectomy pain in any number of studies that we can read will vary between 20 and 70%. It's a wide range, but let's say if you take the average around 35-40%, it's still a huge number given the number of mastectomy patients. And I think while it's likely to be multifactorial, for example, if you have radiation, you have some scarring and tightness, that can certainly play a role in many of these patients. I think it's very reasonable to assume that a number, in fact, the majority of these people suffer from neuropathic pain, which by definition is a nerve injury. So it highlights the fact that when a nerve is severed, for whatever reason, whether it's trauma or because it is near a tumor that needs to be removed, the sequela is not just numbness or dysfunction in the case of a motor nerve. You can end up with pain. Lack of sensation doesn't just mean you don't feel something. It means that part of the body is prone to injury because you lack the feedback to say, hey, there's something wrong here.
Yeah.
And if you've had a reconstruction and you end up with a wound, potentially devastating impact on the underlying reconstruction. So I think even just from a basic standpoint, if you understand that most women are numb after mastectomy because a nerve has been injured or severed, if you can at least identify that may have been necessary, you have the techniques as a peripheral nerve surgeon. We deal with this all the time from chronic pain in the extremities, the ability to manage that nerve injury such that at least, if nothing else, the chronic pain is a non-issue. Happily, we, from mastectomies, don't have a single case of chronic pain.
Yeah.
So this type of approach, which is what we use to reconstruct and manage injured nerves in the extremities and head and neck, has been very effective at the RACS, which is not surprising.
Yeah.
I think that I was just going to say, I think the one thing to add also is I'm constantly surprised by people who have chronic pain, but no one's actually addressed that, that either maybe they brought it up with their surgeon and it hasn't really been addressed, or they don't know that that's not a thing that everyone has, that you have pain after mastectomy. So I think also for people hopefully hearing, if you have chronic pain after mastectomy, I don't want to say it's not normal, because sadly it is a little bit normal, but it doesn't mean you have to live that way.
Yeah.
So, someone like Steve, who's a peripheral nerve surgeon, routinely finds whether it's an injury after an orthopedic surgeon or gynecologic surgery or anything else, that you have these chronic scarred areas of nerves, and we can fix them, cut them, reconstruct them. And so I will say that if you do have chronic pain after mastectomy, it is something to bring up, and it is something to ask for answers for, because just because you've already had your mastectomy and can't have nerve preservation doesn't mean you can't have the fixing and repair of your chronic pain.
Yeah. So that's, again, the hope. For people who are dealing with that on a day-to-day. I think the most important thing hearing this in just knowing what Australia is like is making sure that we are educating more of our surgeons so that they are asking those questions, but also they're capable of fixing that issue.
Yeah. I think that's a huge part of it. I think and I deal with this all the time, because 95% of my practice is peripheral nerve, which means a lot of chronic pain. I think many patients and physicians are frustrated by the fact that they know that there's a problem, they just don't have a way to address it appropriately, and they sometimes know that. So hopefully, this gives people the tools, or at least understanding of what can be done, which will at least prompt them to learn more about it, and ultimately take it up so that they can really help a lot of people.
Yeah. I feel there's a webinar coming
Yes.
up on that topic in particular, where we can deep dive into some of those issues. Yeah. And I guess some of the other things that we were talking about when I met with Cindy and Joe, Dr. Cindy Mack and Dr. Joe Dusseldorf, is translating your experience in the US to Australia and what's capable of happening here, given our different frameworks. Yeah, so just some thoughts there about how we can traverse some of those issues.
I think one of the things that we've been really excited to see, and as I've been giving more talks on this in a more international capacity, you've been realizing some of those things, like access, for instance, to cadaveric nerve grafts that we have in the U.S. that aren't available in parts of the world right now, at least. But what we're finding, which is really neat to watch, Steve, is we continue to evolve. A lot of times now, he's actually able to find nerves that would have to be cut anyway in the breast. We kind of think of them as these spare parts nerves. So we're able to use those as a patient's own nerve graft and not need to have nerves that come from cadavers that are off the shelf that aren't available.
Right.
So I think we're realizing as we're starting to bring these techniques in a more international setting is let's talk to people. Here's how to look for nerves. Here's how to hope that you're finding more than one nerve and you do have these extra ones. How do you assess which nerve to reconstruct, which nerve to cut? And we're finding that we're able to develop this training in such a way that it gives people more options.
Yeah.
So the way that I see it is because there's some surgeons who are already able to do it, let's say with nerves with flats.
Yeah.
They know the concept of connecting nerves. They know the concept. I talked with Dr. Mack about the concept of finding the nerves, not injuring them, using them, tagging them if you're going to reconstruct. And so I think we're at a place where with that option, many people are going to be able, even in the setting of implant reconstruction or flat closure, and not just the flat, be able to have that other parts as well as long as we continue to work on training.
Yeah, I think that's the critical mass. And thank God Australia's borders are open now, so you can come in and we can start to travel a bit more and share those techniques. We were talking a lot earlier about having the right questions to ask your surgeons. Top 2 questions if you were a patient to go in. And if you're seeing a patient and they're wanting to have their options laid out properly to them, top 2 questions.
I think the first one that I would recommend is options. I would ask, in a very clear way, what are the potential kind of, we got risks, benefits, and alternatives is a big picture for consent, but what it really translates to me is what are the potential benefits of this technique for someone like me? What are the potential downsides? And really what is the impact on my life? Because I think a lot of people don't ask, okay, you've offered me a flat reconstruction, let's say, but what does my life really look like? I have young kids at home, I have a busy job, I'm active, like what is my next 6 weeks and what is my next 6 months, right? So ask short term and long term what the impact is going to be. So I think that's kind of the first thing to really get a sense of options and make sure you're putting you and your life into that and where you are. I think the other thing that I love when people ask me is kind of, and this fits with what we're talking about today, is what are the new advances you've brought into your practice and will any of them be applicable and helpful for me? Because what I love about that question is that it gives you a sense of, do you have someone who is on that forefront, that cutting edge, they're thinking about it, they want to have patient-centered care and want to think about new approaches. And if you have someone who has no answer to that or is doing the same thing they're doing 15, 20 years ago, you're probably not getting cutting-edge care. You're probably not getting even standard of care, perhaps, in the day and age we're in now. So in my mind, if you can do both of those parts, hopefully you can get a really great tailored approach that is cutting edge, or at least products support current standard of care.
Yeah, so that they're aware of and employing some of those new techniques. But you do.
Yeah, I would add, I think obviously, as we were saying earlier, sensation matters. It is not sort of an addendum or afterthought in any number of ways of thinking about it and what your life is going to look like afterwards. And I think that to your point just earlier, even if you don't have certain devices or products that we would have in the States, for example, 25% of our cases were in preserved nerves. So just understanding that in some cases, if you are just a little bit more careful in your dissection, you may be able to save that person's sensation and preserve it to the point where most of these issues have been problems. So I think asking that question and at least getting a sense for the fact that your clinician is aware of the importance of that and understands that.
That's why you're here. Thankfully, I'm like, I didn't know that both of you were coming, and I'm so excited because it's almost like the power couple of to Australia. So I'm very excited to see what's next, and we will definitely do a follow-up to see how everything has transpired after your talks here at the RACS conference. And again, I'm just like pinching myself that you guys even got to get here and this is happening. So
Well, we really feel the same way, but we really, it's all thanks to you. It was the connections we made and the connections with our